Welcome to the Dermatology podcast from the Dermatology Education Foundation. AI is a hot topic right now, especially in dermatology, but it's not the only promising technology for the specialty. In this edition of the Dermatology podcast, we'll hear from dermatologist Dr. David Cotter about the potential role for new and emerging technologies in dermatology practice. Plus, Dr. Adam Friedman provides an update on the management of hidradenitis suppurativa. But first, every clinician relies on trusted tools to support decision-making and advance their knowledge. Seasoned dermatology physician assistant and DEF Advisory Council member Darren West recently shared some of his favorite resources during a special career development symposium at the Derm 2024 annual meeting. From apps to hard copy textbooks to tips for career advancement, he has suggestions for NPs and PAs at any stage of practice.
These are things that have guided me as a PA through my career, and has helped me along the way. So I'm just going to review things. So if you haven't been practicing for many years, this is going to be an enlightenment for you. So when I think of resources, I think of what's going to help me as a provider to be a better provider. And that's always first and foremost that I think, what's going to make me a better person? So one of the most interesting apps I think that we've all had is Hippocrates, which, that one I think is a no-brainer. First of all, it's going to help us with our children, our pediatric patients. This app is invaluable. It's something that I pull out at least once or twice a week. And if I need a calculation done really quick, this is where I go to. So think about this app when you're thinking about resources in your pocket. And a lot of you carry your phones, a lot of you carry your tablets or whatever in your room. Have these available to go quickly. All of my drug interactions, I have a lot of elderly patients who need to have their medications checked. And so I pull it out, I do a quick check, and I can kind of verify really quickly that they're going to be okay on certain medications. Especially with the newer medications, some of the JAK inhibitors. You want to just make sure that everything is going well and they're happy. A newer collaboration with the DEF this year is ReachRx. This is kind of nice because it's bringing in artificial intelligence, which we know everything's coming to this forefront, right? And so we have this company which has put a tool together for us, and again, we're kind of happy to be partnering up with them a little bit at the DEF as a meeting. This is a tool that will help you look up information on medications, anything you want in the realm of medications or medicine in general, and it'll put out whatever information they can. I mean, AI is still limited. I think it's still in its earlier phase. But I love this app, and if you get a chance to go at it, play with it, it's really fun. And I think it's only going to get better as it gets further along. So think of this our ReachRx app, sign up for it. They'll even go in and tell you who your rep is in your neighborhood, in your area. You can message reps through this. It's a resource that's really interesting. Visual DX, I have in my pocket, I have it on my phone, I have it out in front of me when I make interesting diagnoses, when I'm talking to my patients, and they don't know what I'm talking about. I pull it out, I do the quick search, I pop up several photos. So Visual DX should be something that each of us has at our fingertips. If you don't have a subscription for it, talk to your office, talk to the people that you work with. It costs a little bit, but our office pooled together and got our entire group a subscription, so we all get it, and I think it's a very valuable resource. So I love the Visual DX. DermNet's free, you can get it online. It's another resource if you don't feel like paying for something. I like this one because it's the same kind of concept. You just need to get into it, log into it. You can find your resources, get that out there. Don't be afraid to show pictures and discussions with your patients. I know we don't have much time. We get 10 minutes at most. And so this is a very critical, or a really nice tool as well. And our patients love it. They really love it when you can engage them and discuss with them. They're not used to that. And so if you can do that, you're going to position yourself as that provider that's taking it to another level, and they're going to love you for it, okay? Some of the journals that have followed me through life, you've all seen these. They're very valuable. The JADA is something that has a very research-based It's a lot of deep reading. If you don't like research, it might be a little bit uncomfortable for you. But don't feel afraid to jump in on that and get in and just start, looking through those articles. It talks about all the latest and greatest stuff that the Academy has put together in different articles. So it's a really neat thing. Dermatology Times and Cutis and Derm News, those are always quick and easy subscriptions. If you don't have them, contact those publications and they will send them to you. 9 times out of 10, it's for free. Books in dermatology that have been paramount in my ground floor work, and again, I've been doing this for years. It's really hard to get good training sometimes. And my doctor I started with was no different. I was with him for 1 or 2 days and I hadn't even done much dermatology, and he's like, okay, go and treat, And so every night I'm looking through these books for hours and hours and taking notes, and he said, just call me on the phone at night after work and we'll talk it over. And it was very difficult. So having resources and information is huge. And so these are 2 books for therapeutics that I like a lot. I started out with Advanced Dermatology Therapy Book 2 with Shelley, and then I found Wolverton, the Comprehensive Derm Drug Therapy book, which is even bigger and a little bit more comprehensive. It goes into details on every drug, spironolactone, all the interesting medications that we write. They're going to have to do some updating with all of the new small molecules and biologics, but right out the gate, all those difficult drugs. And I came from a generation, we were doing cyclosporine, methotrexate, azathioprine. We were writing drugs that nobody today wants to touch. And so we had a lot of that knowledge. And so these are books that helped me gain that knowledge. And so we still need it, and I think we should be understanding of these medications. It's going to cross our paths.
You're listening to the Dermalorian podcast from the Dermatology Education Foundation. Let's pause for this episode's Dermalorian Derm Decoder, in which dermatologist Dr. David Cotter helps make sense of some of the newest technology coming into dermatology practice. There are some concerns regarding certain developments, but overall, Dr. Cotter is optimistic.
Let's start with the positive. Let's talk about areas that hold a lot of potential, things that maybe other members of the House of Medicine are using more fruitfully, but are new to us in dermatology. I'll touch on one. There's an idea of monitoring circulating tumor DNA, for example, to look for recurrence of disease state, whether it's melanoma. We're doing it for other cancers where we'll draw people's blood and do liquid biopsies, and we'll look for markers of tumors in the blood as they circulate to detect recurrence and monitor response to therapy. And what we're actually analyzing are molecules like exosomes, which we're hearing all about in the cosmetic rejuvenative space. But exosomes are these little molecules that are released from cells, little bubbles full of cell information, sometimes DNA, and we can use that to track tumor response to therapy, monitor tumor recurrence, and even predict which drugs might serve a certain patient better than the other. And we're doing the same thing actually on a diagnostic side for disease states as well. Beyond that, though, there's some really great cutting-edge new bedside imaging modalities that we'll be seeing hopefully soon. We know that in dermatology, seeing is believing, and we're pretty good at identifying the common things, one from the other, a basal cell from a squamous cell. And sometimes, though, there's these tough equivocal lesions that are difficult to diagnose. We're not sure if we should biopsy it or not, and a lot of us might just biopsy it. A lot of us might photo and follow and watch it. But we need to do more. So about 20 years ago, reflectance confocal microscopy was developed for in vivo bedside imaging to do a diagnostic imaging biopsy. You can diagnose basal cell and squamous cell and melanoma with RCM, reflectance confocal microscopy. But those are expensive units, they're cumbersome to use, they take up a lot of space, they're not available in your average practice. These are for academic centers. But over the next couple of years, I imagine we're going to start seeing those types of imaging modalities march down to the things closer to the size of your iPhone. And what you'll be able to do is take a picture of an image, maybe use some advanced technology like millimeter wave imaging, for example, which is essentially what TSA does to screen us at the airport. They want to know if you're packing heat when you're trying to get into first class. We can do the same thing to see if that nevus is packing heat, if there's a melanoma hiding somewhere in there. And the way that's possible is leveraging computer learning to take the data contained within that image and extract it and use machine-based learning algorithms to predict a true malignancy score based on what image taken from the patient with specialized advanced imaging. And we see so many new ways. Millimeter wave imaging is one we talked about. There's also multiphoton microscopy, which is a type of in vivo fluorescent imaging. Some people may be familiar with optical coherence tomography. That was a hot new thing when I was a PhD student over 10 years ago, actually 15 years ago now. Time flies. But we've gone beyond just optical coherence tomography, meaning being able to image cells in vivo. We have something now called optical coherence angiography that allows us to measure blood flow in vivo at the cellular level. We can look at vascularity of lesions, which is particularly helpful in diagnosing things you can imagine, a basal cell, for example, but also melanomas. People forget that melanoma is a very vascular tumor. So imagine this. In 1980, the late 1980s, we developed dermoscopy. It didn't achieve widespread adoption for 20, 30 years. Even today, there's dermatologists that don't use dermoscopy. Imagine supplanting your dermatoscope with a bedside imaging device that you could scan a lesion, extract meaningful data from an image standpoint, pump it into a machine learning derived algorithm that's going to give you a malignancy probability score that tells you if you should biopsy it or not. Certainly we know melanoma when we see it, we know basal cell when we see it, but there's plenty of spots that either the patient doesn't want to have biopsied or we're afraid to biopsy because if it's a fibrous papule on the nasal tip and not a basal cell, that person is going to be upset with you. So we're going to be very fortunate to have some of these cool and emerging technologies. Now, things that I don't think will hold much utility, those are going to be things in the AI-driven reimbursement space. Not being tongue-in-cheek, but have you guys had any of those yet? If you're out there listening, where Cigna or Blue Cross Blue Shield has decided to curtail your reimbursement based on an AI-generated analysis of your note, they're taking the personal aspect out of medicine, and that's very unfortunate, and we need to see that come to an end.
Even as technology advances, there is still a benefit to traditional printed textbooks. For Darren West, Rook's Dermatology Handbook and Fitzpatrick's Color Atlas and Synopsis of Clinical Dermatology remain important clinical tools that he keeps literally in his pocket.
Having certain books like this around the office are great because I help a lot of the preceptorships with some of the programs in schools, Creighton and a few other schools in town. And so they come in, and these are books I hand my students. I say, here, read through this, go take it home at night, look at all the stuff we talked about. And even still, once in a while, I'll reference to one of these books. But these are small, compact books. These are little ones, so you should have these kind of handy, especially if you're kind of just still kind of getting a feel for how to view things. So a really good book. Great for teaching, great for being a preceptor, teaching students. The DEF, this organization, it's nonprofit, but it's devoted for education. So if you go onto their organizational website of DEF, you're going to find a ton of resources. Just lots and lots of things. Mentorship programs, there's these biologic boot camps, there's case studies, and I put 2 out this year. I usually do 1, but this year I was able to punch a couple out, and they're really interesting, I think, not being biased or anything. But they're just fun to do. With enough experience, you guys are going to find some really cool cases. And we encourage you guys, not just people in the advisory council, but any of you guys who want to start getting yourself out there to get published, find a case or find something that you have seen that's interesting and put it together in a slideshow. If you watch the way we present, you'll actually get a better feel for how to do it yourself. And then you can present that to us. And I think that's kind of cool in this industry is that people can start to see you. And then there's all the podcasts and webinars, so endless resources. There's the boot camp from the Dr. Boswell. He offers a really, really cool program where you can get a ton of CME at half off if you're a part of this program, and it's very much worth its value. SDPA, and again, they have a thing called the Diplomat Fellowship where you can do modules and learn a ton of stuff. I haven't done it yet, but it's amazing, and I'm thinking of doing it to become a diplomat. Being visible is not, like I said, it's not just publishing and having Qtus put an article out. It's going to LinkedIn. I did a program the other night where I did a speaker program for a company, and right at the end, they took a photo, instantly published it on LinkedIn, and it got out there, okay? And then your face is amongst peers, okay? If you want to be seen, you have to grab the bull by the horns. You need to be out there. You need to be involved. We are a symbiotic relationship with the industry, whether you like it or not. They're the ones that produce the medications that we have to prescribe, that we need to prescribe. So don't shy away from that. Get out there, be involved, and do all of those things that are important. And then in terms of being published, they always need publications. They always need APPs, such as us. They don't have enough of them. You reach out, talk to these organizations. You can have, all of these magazines are looking for people to submit content, okay? It's not rocket science, but have a passion, find something you love and absolutely want to be a niche person with, and just really dive into it. Get it published, talk to them, they'll help you publish, and then you're out there. And then if you're not associating yourself already with all of these pharmaceutical companies and industry today, you're shortchanging yourself, because again, everything that I've ever done started out with industry helping us get to that point. So please jump in and be involved.
You can get more coverage from Derm 2024, including the Career Development Symposium, online at dermnppa.org. Hidradenitis suppurativa has traditionally been underdiagnosed and undertreated, but as we learn in this episode's Dermalorian clinical clip, new advancements may be changing that. Dermatologist Dr. Adam Friedman weighs in.
So hidradenitis suppurativa is one of those conditions that when you hear it, you kind of get a chill down your spine. This is a horrific condition that is life-altering, that has really been put in the corner for many years, kind of treated like the ugly stepchild of dermatology, which is so unfortunate because we have so many great tools to help these patients, who many of whom can't even lift their arms, let alone sit down, because of the pain associated with the active lesions. We've seen a lot of growth and a lot of interest in this area in the last several years. We had adalimumab and still have adalimumab, and as well as biosimilars that we can utilize for hidradenitis. More recently, secukinumab just got approved, which is very exciting. I think many of us in this space have been using biologics off-label, which is not the easiest things, and that's where samples can be very helpful. So being able to actually get insurance to cover a medication that's needed lifelong, or for at least for a very long time, I think is very helpful. And I would even argue showing patients that, hey, there's another FDA-approved drug, it validates their experience, it gives them confidence in the medical system, and is a sign of hope. We actually did a study at GW in partnership with HS Connects, asking that question, is knowing that there's another FDA-approved drug, what does that mean to you? And of course, HS patients were really excited, not to mention that having more options increases uptake in terms of dermatologists taking care of these patients, which has really been a problem because we know these patients can bounce around to primary care, ER, ID, rheumatology, you name it, and the average time from onset to diagnosis is still 7 to 10 years. That is absolutely unacceptable. We have to do better by these patients, because often by that point, they already have extensive scarring, sinus tracts, tombstone comedones, things that medical therapy will not get rid of. They will need surgical intervention. In an ideal Disney film type world, we would get to these patients before they have significant permanent damage. And that's really what we're trying to do. And I'm hopeful now, with a very rich pipeline of both biologics, small molecule inhibitors coming down the road that are going to be FDA approved, not the litany of off-label options, everything from antibiotics, including dapsone, to anti-hormonal therapies like spironolactone, to even small molecule inhibitors like roflumilast. Wouldn't it be lovely if we have things that are supported by sizable studies and really give us insight in terms of how will a drug behave in all HS patients? That is sorely missing. So I am really excited about both the systemic and even topical pipelines coming up, and I can tell you HS patients are as well.
So can clinicians make a difference for HS patients?
It's an interesting question. Are we at a point where we can really make an impact? And I think that point has always been there. And the reason I say that is, one, if you give the time, if you sit down, get eye level with these patients, you hear their experiences, and you partner with them, no matter what you do even medically, that is already a success. These patients have been ostracized, they've been dismissed, they've been told that they're dirty, that they're conditions because they eat too much, they smoke, which, by the way, that is not true. There are so many different pieces to the overall burden of disease puzzle that just simply saying, I'm going to work with you. I'm here to help you, and we're going to do this together, and we're going to figure it out. That alone is therapeutic. So I think we've always been able to do that, and I think we're doing more of it, but certainly more work is needed. And there are foundations and organizations that help with this. As I mentioned, HS Connect, in a previous section, is a wonderful patient-driven organization that really allows patients suffering to know that there is a very large community that gets them and is also there to support them. So from that perspective, I think we can already be doing that. From a therapeutic perspective, as dermatologists, we are the off-label bandits, and HS is a great example of that, right? Mostly everything we do, even, biologics like infliximab, ustekinumab, bimekizumab currently, we are using these because we can access them and we can finagle and figure out ways to, be the Robin Hoods of HS and get patients the medications they need, not to mention even long-standing medications for other indications like metformin, spironolactone, doxycycline, clindamycin, and rifampin, the list goes on and on. So I think that with even those tools, we can do quite a lot. You just got to be willing to do it, but also you have to revamp your mentality and think, I'm going to try one thing, that doesn't work, goodbye, try another. Rather, it's dumping the kitchen sink. It's piling on, and you don't start low, work your way up, because many of these patients are already moderate to severe by the time they get to us. So combining therapies that address different facets of disease, the hormonal component, the inflammatory component, even the dysbiosis component, which we know these patients have microbial dysbiosis, addressing all of those can culminate in treatment success or at least some improvement. Because these patients, some of these, they're walking, if you can't do something for me, I'm done. We know there's increased risk for suicidal ideation and even execution of suicide. So these patients are just looking for any bit of relief. We have to take a multimodal approach, and we have things that can help. But the great news is we have many more things coming down the line, some of which, even if they are not indicated yet, we can still mess with a little bit. And I encourage people to really, put on their off-label, cape and really try to utilize things that you're using for other things already. You know how these things work, and work hard to really get these patients feeling better, because this is an extraordinary disabling condition.
That's it for this edition of the Dermalorian podcast from the Dermatology Education Foundation. If you enjoy the podcast, share it with a colleague, and catch up on past episodes wherever you listen to podcasts. We'll see you back here next month.